but it also can be in the foot, okay? Or it can be long bone compression, where you're grabbing either side of the joint or the head and the base of the bone and compressing it together, okay? So that's a fracture test. You can also have percussion, where you flick the tip, okay? Or you press on it, you hit on the bone, any bony protuberance to try to elicit a pain reaction, okay? And then bump test is more for the lower leg. Did that hurt? Great. So again, you're looking for pain that is different than where you're hitting. So when you're flicking the tip of the toe, you're actually probably testing back in here, and you're looking for a change in the pain, okay? You're not looking for pain on the tip of their toe. You're looking for it in the bone. Same with the bump test, same with the compression test, okay? You could be in a really aggressive palpator, and you palpate it, and then they say, oh yeah, that hurts. Ask them, where does it hurt? If it hurts right under your fingers, they're probably soft in a nice way. If they're hurting somewhere in the middle of the bone, it's a positive test for fracture, and we need to get it eval somewhere else, okay? When we're looking at our different glides, okay, you can have a glide at any joint space, okay? So you can have it between your, different phalanges, so I can glide a joint in my phalanges. I can glide a joint here. I can glide a joint here. I can glide joints this way. I can glide your midfoot, okay? All it is saying, okay, I'm gonna isolate one side of the joint or the area. I'm gonna isolate the other, and then I'm gonna glide it in the direction of the bone or the joint, okay? I'm not gonna try to glide it this way. I'm gonna glide it with the way it bends. So everything in the foot is all gonna be up, down, okay? And then if it's between these ways, we're just gonna glide up, down in this pattern, okay? Because we're looking to see if the muscles, our intrinsic muscles, are moving correctly. Does that make sense? Okay, so go one side, other side, and just move it. It's easiest with fingers and toes, okay? If you don't feel like you're getting it, move to the hand and the wrist, okay? Just to get the feel of what a glide should be. Gliding the wrist is really easy, okay? And when I come down and around to do the anterior drawer, I can also glide you guys, so that way you guys can feel what it's supposed to feel like. So then you guys can give feedback to the people doing it, of whether they're doing it right or wrong, okay? Then when we're doing our valgus and our varus, remember valgus makes an L anytime you're doing it, and varus, you open up, okay? You go out. So when you're looking at doing it on feet and hands, it gets confusing. Remember, feet and hands, midline is always off the foot, okay? Or the midline off the body, okay? So if I want to test the foot, I'm going to sandwich both sides of the toe, so I'm on either side of the joint, and then I'm going to wiggle back and forth. So I'm testing the ligaments this way, and I'm testing the ligaments this way, okay? Again, it's easier with the hand if you're wanting to practice. Same concept as the toe. Isolate each side, test, test, okay? You'll feel a really good end feel, okay? If you put it into bend, you can also get it to open up. So when we do the knee, especially for testing later, it does help to do it at 0 degrees and then about 30 degrees. Toes, it gets a little harder with the 30 degrees, because let's be honest, 30 degrees of a toe is just a little weird detail. But it does help, so sometimes you need to do 0, test, make sure we don't have any issues, and then test again. So what we're looking for is we're looking for an avulsion fracture, or we're looking for a ligament injury with our valgus and varus stuff, okay? Then we're going to do anterior drawer. So anterior drawer in the book is usually taught seated. I do it seated with legs off the table. So come this way. The difficulty with this one is you have to get on the ground or you have to sit in a chair and wheel up. So then you're stuck down here, and it's just not as comfortable to test. Okay, so you grab the heel, you use the forearm to support so the foot is at 90-90. you stabilize the tib fib and then translate forward, okay? I don't prefer this method, but it is a method that's taught most places, is to do it seated off the table like this. I like to bring it back into a long sit. This is anterior drawer. Yep. So the anterior drawer I like to do is the same positioning, but now I'm going to use the table to stabilize and my hand to stabilize tib fib, okay? Especially when you're getting to taller, bigger feeted individuals and you're somebody smaller, their foot is big. Like a size 16 goes up to like here, okay? So use your arm to get that position into 90-90 and control, okay? If you try to test over here, you're not gonna get the drawer to open, okay? It's not gonna open. Use your forearm, even when the foot's sweaty. Hold on to the calcaneus, stabilize tib fib. If you have to get on your tiptoes, get on your tiptoes and translate up, okay? This, and then they push forward that way.
Yeah, something like that.
Yep. So when you're usually looking at closed chain stuff, it's the opposite of what you were doing before. So instead of the talus moving forward and translating over the tib, you're now making the tib translate over the talus. When you're usually doing this one, this is more not a special test. It's going to be more of a test for it's a joint mob more than it is a test for actual stability. So you can translate this way on somebody. It is possible. Or you can have her push forward into it. Like if she stood on the table, stand up. I could have myself stabilize the talus and then her move over it, and I could get motion. But again, that's not going to tell me if she has an end feel or not. It will just tell us if she has pain. Okay? Thank you. I'm going to also now use your foot again.
Okay.
So now we're going to hit into our couple other tests. So Homan sign is for a DVT, or a deep vein thrombosis. And you just literally squeeze the calf and see if they have pain. Okay? The bigger things for this one is A, did they travel over 2 to 3 hours in some type of form? And if they're female, are they on birth control? If all 3 of these things are yes, that's 4. If all 3 of these things are yes, get them in to see someone ASAP for a Doppler and get them treated because they probably have a blood clot. Okay? Flip over.
That's scary.
So now we're going to test Achilles. So now we're in Thompson test. All you do is you take the calf and you squeeze it. And by squeezing it, you watch for the little reflex of the Achilles to pull this guy up. In every Achilles things I have seen, this test never needs to be done because you clearly see the Achilles has ruptured and it is no longer there. So it's a good test to know if you're dealing with a partial rupture. I have never had a partial rupture. I've always had fulls. So you can squeeze and you see the little foot flick. There it is. Okay? Very easy test. Flip back over. So now we're going to do our 2 Taylor tilts. Posterior drawer is typically not done because the Achilles prevents the posterior from getting tested. So if we think of the anterior drawer going this way, the posterior drawer just goes back. So you stabilize talus and you push back. Achilles will prevent this movement, so most likely you won't get a positive test and you probably don't ever need to do it. Okay? The tilts, I'm going to use your other foot for filming purposes. So your 2 tilts. So if you want to do an inversion test, you get them into a neutral position. I like to have either finger on either side of the talus. So if you can imagine the talus sitting here, I have fingers on either side so I can control the talus. If you're too low, you're on calcaneus, and then you're going to get the calcaneus talar joint, okay? So get right on the talus, and then your trick is straight inversion, straight eversion, okay? If we're testing this way, what ligament are we testing? Spring, maybe. Try one of our lateral ligaments. Fibular calcaneal. Good job. Okay, so now we're testing that middle of our 3 ligaments on the side. As soon as we go to do an eversion, we're now testing what ligament group? Deltoid ligament group. Perfect. So if you think of anatomy and what direction you're mostly stressing, that is what you are testing. Make sense? The next one we have is Clyder's, which is probably one of your harder tests to get proficient at. So this is for your syndesmosis or your high ankle sprains, okay? Your high ankle sprain is between your tib and your fib. Your goal is to basically jam the talus into the ankle mortise or capsule and then turn it out to push the tibia to piss off the sprained ankle. Does that make sense? If you can think about it in that pattern, you will probably always be able to do Clyder's. So you want to bring it into the neutral position, okay? Same type of positioning for anterior drawer. You want to load it, you want to evert it, and dorsiflexion. So you are now taking that talus and using it to fulcrum the fibula to see if we can push the fibula out of the way and open up this mortise, okay? High ankle sprains suck because every time you weight bear, that talus is pushing that mortise apart. That's why they're booted for so long. So in a test, that's what you want to simulate. You want to simulate a load, a shift, and push that talus to piss off that fibula to open the joint up, okay? Then a positive test, you'll have a little bit of opening, but you won't have the type of opening with an anterior drawer. Most of the time, you're just going to get a lot of pain, okay? Distal tibial fibular glide, you just kind of do this number. So Fife's line, supple pes planus, navicular drop, all 3 of these tests are more linked into gait stuff and watching where the foot is. So, you have them sit in a chair. Okay, so if we wanted to look at our foot, for a navicular drop test, usually what you do is you just put like a sticker or a mark on their navicular tubercle. Then as they stand up, you just watch if that dot moves down. And you watch for the navicular to drop. Okay, that's all you have to really do. Fife's line gets a lot more fancy. Fife's line, what you do is you get on the ground, which is super fun for anyone that needs to do this. You get on the ground, you take a piece of paper or a note card, you put a line where their navicular is, okay? Then they stand up. Then, yep, you can be partial weight bearing. I need open feet. There we go. Then I take this again, and I mark now where the navicular is, and then I measure the distance between. Okay? So, thank you, that's beautiful. Supple pes planus, you just kind of watch to see if they flatten out. Both very easy, okay? Hop back up, we'll do the last 2. Morton's neuroma, you're looking for basically irritation of the nerve between the toes, okay? They're gonna report pain in between their metatarsals, and it's gonna be between like the third and fourth, but sometimes it's second and third, just because they have swelling or irritation, okay? Super tricky, complex test. You squeeze their midfoot. If you increase their pain, you have positive. Really a complex one. Just straight squeeze of the metatarsals, okay? Tinel sign, you're basically trying to irritate the nerve to see if the foot tingles, okay? So we're all aware of the Tom, Dick, and Harry of the inner foot. So basically you go to the nerve and you just sit and try to tap on it. Not super useful. The only time I've really had a good Tinel sign is in the elbow, okay? The rest of the time, you're 50-50 on your Tinel signs. And all you're doing is basically a progression in the area of a nerve. So it can be any nerve.